Welcome to this podcast from the Medical Journal of Australia. My name is Sally Block, the MJA's news and online editor. Today we're exploring the diagnosis of Alzheimer's disease, treating dementia, and how nutrition can help with cognitive decline. This podcast is sponsored by Macquarie University Hospital, part of Macquarie University Health, a trailblazer in healthcare, education and research. Professor James Burrell is a consultant neurologist and Professor of Cognitive Neurology at Macquarie University with subspecialty expertise in cognitive and behavioural neurology. He has established a young onset dementia clinic and leads research into atypical dementias. He treats both common and rare neurological disorders including stroke, epilepsy and neuromuscular conditions. He is highly skilled in clinical neurophysiology, including nerve conduction studies and EMG. Dr. Heather Francis is an endorsed clinical neuropsychologist. She is experienced in the diagnosis and management of neurological and neurosurgical conditions. She provides evidence-based cognitive and lifestyle recommendations and interventions to improve brain health and mental well-being, as well as reduce risk of cognitive decline in ageing. She has a research interest in the effects of diet on the brain. They join me now. James, so the first question is, how have new diagnostic tools like CSF analysis and amyloid PET scans changed the way that early and accurate diagnosis of Alzheimer's disease in Australia?
Yeah, thanks, Sally. A fantastic question. I think that this is an area which has undergone a revolution in the recent past, actually. Prior to the availability of these biomarkers of underlying Alzheimer's disease, we would make a clinical diagnosis solely based on the pattern of any clinical symptoms, how people went on cognitive testing, and we'd use other tests to basically rule out other potential causes of their problems. But we were always left a little bit in the dark in terms of trying to confirm underlying Alzheimer's disease pathology. And we know that there are other neurodegenerative diseases that can cause very similar symptoms to Alzheimer's disease. And so we always had to sort of hedge our bets a little bit about whether we're actually truly dealing with Alzheimer's disease or one of these other conditions that presented in a very similar way. As I mentioned, this has changed very dramatically just in the last couple of years. We now can confirm underlying Alzheimer's disease pathology with a high degree of accuracy, either through CSF analysis or with an amyloid PET scan. And there are pros and cons of each approach that we can come to perhaps. But I guess the practical implication of this is that when we are seeing patients with very early symptoms, we can now use these biomarkers to determine if those symptoms are due to underlying Alzheimer's disease, at a very early stage. So people who might be concerned about cognitive symptoms, we can, in some cases, rule out underlying Alzheimer's disease. Whereas in the other situation, if people have early symptoms, we can rule in Alzheimer's disease at an early stage and make sure that they're getting all the appropriate therapies, both medication and non-medication. So this has really dramatically changed our practice in the last couple of years.
With the TGA's approval of new anti-amyloid therapies, what are the key implications for patients, particularly regarding access, funding and eligibility?
Yeah, look, I think one of the things driving the access to these Alzheimer's disease biomarkers is, of course, these new therapies, anti-amyloid therapies, of which there are now two that have been approved by the TGA for use in Australia. These treatments target amyloid, which is one of the characteristic and early pathological changes in Alzheimer's disease. And the, concept behind these treatments is that removing amyloid at an early stage prevents the accumulation of further damage through the deposition of a protein called tau, which can lead to neuronal loss, cognitive symptoms, and ultimately functional impairment. So these treatments target the amyloid, which is the sort of earliest step along that pathway, and they're very effective at removing amyloid on amyloid PET scans, for example. And there is now very solid evidence to show that removing the amyloid can have a positive effect on the clinical progression for patients over now up to 4 years for one of the particular agents that we're talking about. So if we're going to use these therapies, first of all, we need to make sure that we're only using these therapies on patients who have underlying Alzheimer's disease. But we also want to try and target those patients at a very early stage of disease. So we want to get to the point where they have amyloid being deposited. There's perhaps some early changes going on and early symptoms that we can record, but not so much damage that the treatments are no longer indicated. So it's about trying to identify those patients who have Alzheimer's disease, but also identifying them at an early stage so that we can try and get them onto these treatments. Now, the therapies that we're talking about are quite involved therapies. Depending on the drug, they're either fortnightly or monthly infusions, and the initial treatment course is an 18-month time period. There's lots of monitoring for safety and so forth. So it is quite an involved process. At present, the medications have not been approved on the PBS. So they are approved for use in Australia, but there's no government subsidy or funding coming through the PBS at this point in time. So most patients will have to self-fund these treatments, and that's obviously something that that will have to be looked at over time as evidence accumulates about their clinical benefit and how much of a cost benefit that may have for our society. So these treatments are obviously the way that we're going in terms of medical treatment of dementia. That's not the only component, but it's an important one. And in order to use these treatments effectively, we need the amyloid biomarkers, such as the CSF analysis and anti-amyloid PET scans.
Now, with those medications, are they out of reach of a lot of people because they aren't on the PBS?
So at present, that will be the case. So, these therapies are very costly, not just the actual medication, but there's quite a lot involved in terms of, administering the medication, monitoring for safety and those sorts of things. So that will put it, unfortunately, these therapies out of reach for a lot of people. And I think, I guess I would make the point that I think we're a little bit too nihilistic about the treatment of neurodegenerative disease and dementia in Australia. There's a view that, these therapies are too costly, too risky, and that their benefit is not sufficient to justify their use. But I think that the risks of the treatments can be mitigated, and I think we're currently underestimating the benefits of these treatments, particularly if we're identifying those patients at a very early stage of disease. So I think going forward, I think the evidence will start to accumulate to show that if we target the right people and treat them at the right time, we'll actually make a massive impact to the trajectory of Alzheimer's disease in our society. And I think that will have flow-on effects to government support services and so forth. So I think we're too nihilistic. I think we should be embracing these therapies. There may be new therapies where that cost risk benefit kind of equation changes as well, but these are the first therapies that we have, and my view is that we should be doing our best to try and get as many patients as possible to the point of accessing it.
And with these new diagnostic tools, how do these new diagnostic tools help to distinguish Alzheimer's from other types of dementia, and why is this important for managing patients?
Yeah, so as I mentioned before, we had access to any of these diagnostic tools. We just did what I would regard as being a kind of detailed clinical phenotyping. So that is collecting the symptoms, collecting the kind of the signs, if you like, through a clinical assessment. What types of problems did people have? We'd use we'd expand on that using formal neuropsychological testing, and then we'd look at things like MRI scans, sometimes FDG PET scans, to just give us a bit more, substance behind what was ultimately a clinical diagnosis. These tools, help us enormously because, as I said, in those clear-cut cases that are due to Alzheimer's disease, we're making a very early and accurate diagnosis, even if the clinical presentation might be a little bit atypical, or, all of the criteria at a clinical level may not quite be met. So that's one use case. The other use case, of course, is if the testing is completely normal, then that's obviously very reassuring for people who might have symptoms. And perhaps in that context, we might look at the effects of things like, sleep disturbance, low mood, other factors that could be contributing to their symptoms that aren't related to underlying Alzheimer's disease or some other neurodegenerative disease. And then the third scenario is that the patient does have a neurodegenerative disease, but it's not Alzheimer's disease. Now, in that setting, there are, without getting too technical, there are some changes that we can see sometimes on the CSF analysis that tell us that there's a neurodegenerative process. but help us to rule out Alzheimer's disease as the cause of that neurodegenerative process. And I've certainly had a number of patients where, I thought based on their clinical phenotype, if you like, that they had Alzheimer's disease, but their scans actually, the amyloid biomarkers actually revealed evidence of another neurodegenerative process, such as frontotemporal dementia, for example. So I think, these tools are really extending and changing the way that we, make a diagnosis of dementia. It used to be that we would just, kind of limit ourselves to the clinical phenotype, perhaps with the addition of formal neuropsychological testing, which could help flesh out that phenotype, if you like. But we're now at the point where we have, biological biomarkers of underlying disease. And so that's incredibly powerful. And it starts to challenge some of those often off or long held maxims about, what these different disease processes look like and what they are.
So how do these tools work in terms of perhaps changing the course of the disease at an earlier stage? So if you can catch them at this earlier stage and be very specific, does it have a big influence on the outcome for the patient?
Yeah, so obviously these tools allow us to make an early diagnosis of Alzheimer's disease in those patients that have that underlying condition. And if we can get them onto therapy, we now, and I should say medical therapy, if I make that distinction, we now have evidence over a period of 3 years for one of the medications and 4 years for another medication, showing a significant reduction in the rate of decline in patients treated with these therapies. So that's now very clearly established. When you start to look at subgroups, though, so as I mentioned, the earliest and most characteristic feature of Alzheimer's disease pathology is this deposition of amyloid pathology. But following that is the deposition of another protein called tau, and it's probably tau that does the damage. One of the approaches that both of the researchers studying these anti-amyloid therapies have taken is to look at patients on how much, categorized on the basis of how much tau they have. So they divided their patient groups into patients who had low to medium levels of tau versus those patients with high levels of tau. And the results in the patients, and this is sort of logical, based on what I've just said about amyloid leading to tau deposition, leading to neuronal loss and functional impairment. If you take the low to medium tau group, their rate of decline is dramatically less than the patients who have a high burden of tau. Now, both groups benefit, but the benefit is much greater in the group that have low to medium levels of tau. And depending on how you measure it, some of the studies have even suggested that the rate of decline is so small that it's sort of barely detectable over a period of a number of years. So this is really a dramatic finding. And I think it sort of, really enforces this idea that we need to find people early, we need to treat them early, we need to prevent the neuronal loss, which leads to functional impairment. So I didn't say this before, but I should just mention that the two medications have been approved for use in what's called mild cognitive impairment, which is where patients have clinical symptoms related to Alzheimer's disease. So they have some perhaps memory impairment, for example, that you can detect on clinical testing, but they don't have any functional impairment. So these are people that are still living independently, probably have noticed changes in their memory, maybe a bit more forgetful than usual, and we can detect that on testing, but are still living a completely normal life for all intents and purposes. So that's one group that these therapies have been approved for. And the other group is mild dementia, where people are still living a very good life, but they may need a little bit of assistance with some of the more complicated activities of daily living. So it's that end of the group that we're targeting. And then within that, if we look at the patients who have, a low level of tau deposition, then they are significantly benefiting from these therapies.
And so these therapies aren't a cure, but they significantly slow the decline.
So, the official party line is they're not a cure. Absolutely. And certainly if we take the patient groups as a whole, they still decline, but they decline much more slowly than patients who are not treated with these therapies. And, the benefit is so significant in that low to medium tau group that it's a bit of a provocative discussion, but if you get to the point where you stop people declining, at what point do you regard these therapies as a cure? Personally, I don't think we're quite there yet, but it's certainly such a dramatic result that people are starting to think about, well, how much better can we make these therapies? How much of a difference can we make in patients' lives who have early Alzheimer's disease?
And so for GPs, at what stage is it most beneficial for them to refer a patient onto someone like you for these treatments when it's so hard to detect in these early stages?
Yeah, so I think the biomarkers we're talking about, are not easily accessible. So amyloid PET scans, for example, are not available everywhere, and again, they're not covered by Medicare. So there is a significant cost to the patient to have an amyloid PET scan. Lumbar punctures or CSF analysis are probably more widely accessible. The cost of doing the testing on the CSF is much less than it is for amyloid PET scans. But it's also an invasive test. You have to have a sample of the cerebrospinal fluid taken from the base of the spine. It's a very safe procedure, but understandably, patients are often not keen on having a lumbar puncture. So those particular tests are not easily accessible for different reasons. I think we might come on to what the future holds in a moment, but for the moment, I think if patients are concerned, particularly if they have impaired scores on brief cognitive screening tests, things like the Montreal Cognitive Assessment or the mini mental status examination, if people are scoring in the impaired range on those tests, they should really be referred on to either a neurologist with an interest in these things or perhaps a geriatrician, depending on their age. But that would be, I think, the easiest thing for the GP to use as a sort of trigger for needing to refer people on. I think we're at the stage where it's probably better to err on the side of caution and send them a little bit too early. Rather than sending them a little bit too late. Because even if we do the testing and we decide, well, you don't have Alzheimer's disease, we can obviously, still give the patient advice on how to manage their symptoms and whatever else they can do to try and optimize their brain health going forward. So we're very happy to see patients at an early stage. Again, I think we've been too nihilistic in Australia about dementia care. I really think we should be moving away from this idea that, you only refer somebody when it's obvious that they're really badly demented. There's a limit to what can be done at that stage. We want to see people early on. Not all of those patients will have dementia, but that's okay. That's part of the process. And trying to optimize brain health is an important part of what we do.
So, on that note, in optimizing brain health, what apart from medication should we think about when managing patients with dementia?
Yeah, so look, for a long time, we've advocated for, generally sort of healthy lifestyle interventions to try and support brain health. But the evidence for that approach had been fairly limited until recently. So we now have a couple of big international studies. One is called the Finger Study, which is the one I remember and tell my patients about, which is a Scandinavian study. But a similar study was done in North America as well. But the Finger Study basically looked at 5 interventions. That's why it's called a Finger Study, easy to remember. The first intervention is to encourage intellectual stimulation. The second is social stimulation. The third is physical exercise. So physical exercise is beneficial for brain health. People don't always realize that, but it's true. The fourth is managing any vascular risk factors. So things like stopping people smoking, controlling blood pressure, cholesterol, diabetes, those sorts of things. And then the fifth one is diet. And the diet intervention that they looked at was largely based on a Mediterranean style diet. So lots of vegetables and fresh fish and low in saturated animal fat. And the Finger Study, when implemented, showed that as a very significant proportion of dementia risk can be mitigated. So we're talking 30 to 40% reduction in the rate of dementia by implementing these sorts of interventions. Now, whether the impact is as high in patients who have already started to show signs or perhaps have early dementia is a bit less clear. But I think it's really critical that we give people something to do that will, potentially have a beneficial effect on their outcome. So, I'm a keen advocate for these sorts of lifestyle interventions for all of my patients where we can.
So, Heather, with your specialty, can you tell us how diet and nutrition supports brain health and influences cognitive decline in aging and dementia?
Yes. I guess if we're talking about, diet and exercise sort of specifically, I tend to ask my patients usually about their typical day-to-day diet. And we know, like exactly from the studies that James has talked about, that diets high in processed foods, so high in saturated fat, high in refined sugar, tend to predispose people to developing dementia. And there have been some studies sort of in that mild cognitive impairment space that have shown that being on a healthier diet can reduce the risk of sort of further cognitive decline or slow the cognitive decline. And so usually what I'll be talking to patients about is going on to sort of trying to eat more whole, unprocessed foods. There's a biggest literature around Mediterranean diet and sort of how the aspects of that, things like, dark green leafy veg, fruit and berries that are rich in colours, using olive oil and substituting that for sort of other sort of, more highly processed refined oils. A lot of those switches can reduce the risk of cognitive decline. I guess maybe if we're talking about my profession being neuropsychology more generally, I guess I'd like to sort of go back to one of the themes that James was coming back to, which is that sort of the early identification and the benefit of it, and how Australia has typically been a bit nihilistic in what's the point in referring on, because there's no cure, what can you do anyway? And I think from my perspective as a neuropsychologist, we're sort of moving away a little bit, maybe becoming a little bit less relevant in the diagnosis phase of things. We've got much more sort of technological biomarkers, but we're really, a lot of the time, I think, very involved in helping people to live well with dementia. And so even still doing those neuropsychological tasks, seeing sort of the type of symptoms that they have and the level of severity, and then helping them and also usually their family members manage those, I think is really important. And the types of recommendations that we give are going to very much depend on the stage of dementia that they're at.
Could you give us some examples of what you would recommend for the different stages?
Yeah, so again, if they're sort of in that sort of milder stage, it's usually we'll talk to people about early management of, getting in there with all their sort of legal planning, discussion of who manages the finances, getting in early with enduring guardianship, power of attorney. And we'll usually put in place, some sort of recommendations about cognitive supports. And again, that's going to very much depend on, first of all, the stage, the level of severity of the cognitive symptoms that they're experiencing. If it's very mild, it might be putting in place external aids, memory aids. If it's later in the disease course, it might be putting in place sort of environmental modifications, labels on drawers, reminder systems to help people remember the main things that they need to remember. And that's if their primary difficulty is a memory difficulty. So again, James talked about, that there are different dementia profiles, and we've talked a lot about Alzheimer's disease. And so we would recommend memory aids for people with Alzheimer's disease. But if someone's, for example, got a frontotemporal dementia, our approach to helping manage that person's symptoms is going to differ because they're likely to have more sort of planning and organisation difficulties. They may actually lack insight into their condition, and so you might need to be working a bit more closely with the family to help them understand the condition. So a lot very much depends on the condition that person is presenting with.
So what role does physical activity play in maintaining cognitive function and independence in people with dementia?
Yeah, so again, that's sort of probably the lifestyle factor that has the best evidence backing that a good exercise regime will improve cognition. In terms of the type of exercise, we know that both cardiovascular, sort of more fitness type activities will improve brain health, but also strength-based exercises. So a lot of the studies will say that people who maintain a good muscle mass into older age tend to experience less cognitive decline. So that being said, I'm always just tailoring an exercise intervention to the person because it really depends what their baseline is. So asking them what they have done before, what they're going to do, because frankly, the best exercise intervention is the exercise intervention that they will actually do.
There's a lot of, just out of interest, I mean, there's a lot of, you see it on social media, a lot of different exercise programs targeted at people who are middle age. And it's like there's things like wall Pilates, there's HIIT, there's all these different things like these short, intense exercises, like for say 10 minutes. What would you recommend would be best for, let's say, a GP recommending to their patient who wants to maintain their fitness as they get older, but what are fads and what are things that'll work? Is it going for a 20-minute walk a day? Is it your 10,000 steps or 8,000? Because then they say 8,000 is good enough. Like, what would you actually recommend?
Again, I mean, my biggest recommendation is some exercise is better than no exercise, and don't let the perfect get in the way of the good. So any incremental sort of change is a benefit. Some studies, for example, have even shown, the benefit of gardening and other incidental exercise compared to just remaining sedentary. I guess if I'm thinking from a GP's perspective, what they could recommend is if you can ask just a few brief questions about the person to get an idea of where they are currently. And because if someone's never really been into exercise, you're going to be maybe trying to get them to introduce, say, a few walks a week. Being in nature is also good. If you can do it in a group, then you're ticking that box from the fingers trial of socialization as well, which we know is good for the brain. But it's very tricky. It really depends on an individual's circumstances. If they've got the funds to support it, ideally, going and having some sort of personal training or exercise physiology input. What you referred to before was HIIT, the HIIT training, high intensity interval training. And that does have good evidence to support benefits to cognition. I guess in an ideal world, you'd be doing a combination of that, sort of gets your heart rate up, but on alternate days, you might want to do, say, some strength-based exercise to increase muscle mass.
And would you is that sort of looking at something like Pilates or yoga or that kind of thing, or working with weights at a gym?
When I say strength-based, I typically mean, I guess, a lot of the studies are looking at, yes, weights to increase muscle mass. But again, if someone will attend Pilates, that there's studies that have shown the benefits of yoga, the benefits of Pilates. The other things that the good thing that Pilates and yoga will do is that they get the person to focus on their breathing, which is good for relaxation, which again is sort of another thing that I'll try to introduce with my patients, particularly. And again, it really depends on their main presenting symptoms. But if they've got either a comorbid depression or anxiety, which is very common in neurodegenerative conditions, then trying to tackle that with sort of relaxation as well is often an approach that I'll take.
This ties into what we've been talking about, but which lifestyle strategies such as structured routines, social engagement, and cognitive exercises are the most effective in supporting patients with dementia and their carers? Like, my father is 80 and he does a crossword does a Herald crossword every day. Are we talking those kind of things?
So I guess there's sort of two things I maybe want to make sure I address there. And the very first one is I often get asked about sort of online or computerized cognitive training. And I think the research in general, I think, shows that it depends, right? But in general, with those cognitive training programs, there's an opportunity cost. They only make you better necessarily at doing the particular cognitive online training program. They don't really generalize that well to outside of that particular, to other types of cognitive function. But on the flip side, what we do know really works is doing something novel. So doing and getting your brain thinking and working in different ways. So if doing a crossword is your jam, that's fabulous and it's getting your brain thinking, but also every now and then trying to introduce something a little bit more novel and different. That's why things like learning another language, learning an instrument, all those sorts of things, it's getting your brain almost exercising it in a different way to what it's used to.
And I guess those sorts of exercises and things would help mitigate depression and anxiety, as you said, that coexist in early stages or in stages of dementia.
Yeah. And actually, one thing that I didn't say in relation to all of that was social interaction is in itself sort of its own form of cognitive stimulation, right? Because you don't know what the other, you're interacting with other people, you don't know what they're going to say or do. So you are sort of thinking in different ways usually. And so that's, again, that opportunity cost. If computerized cognitive training is going to replace sitting on the couch, not doing anything else or scrolling on a phone, that's probably a good switch. But if it's going to replace social interaction, then I think that the science shows there's not likely to be a benefit of it over and above that.
So even if you're interacting with your friends on Messenger or something like that, it's not the same as picking up the phone, having a conversation or being in front of someone. Is that what you're saying?
No, I guess I was more saying those sort of there's those online training programs, cognitive training programs, sort of comparing that to social interaction. Of course, I do always advocate more for face-to-face is always going to be sort of the most cognitively stimulating. Yeah.
How much do you think that in an era of where we scroll and our brains aren't required to do as much work, how do you think this fits in with what's happening with dementia and Alzheimer's?
Oh, that's a big, heavy question. I guess, this world where we can just live on a phone and not interact as much with other people concerns me a lot for all of those reasons. And, I think smartphones and being online have a lot of negatives in terms of our attention, our ability to pay attention for long periods of time, and also in terms of our mood. There's a lot of upward social comparison that induce feelings of anxiety, depression. There's also a lot of, things online that we're not meant to encounter day to day, big sadnesses of the world, the horrible things that are going on in the world, and just our ability to process those. And I think, of course, anxiety and depression feed into risk of neurodegenerative conditions. And I know James is probably going to have a fair bit to say on this as well.
Yeah, look, I agree with everything you've said, Heather. I think that, there's obviously a lot of potential harm that, social media and smartphones can introduce. I think in the setting of dementia specifically, most, if not all, of the neurodegenerative diseases probably take a couple of decades to start to develop. So there's a lot of pathological changes that are happening in the background without there being any clinical symptoms at all. And so I think in that context, the iPhone is only about 15 years old, right? So we don't really know what the impact will be on the use of this sort of technology for dementia risk specifically. I think some of those issues about, social isolation, the need, some of those negative kind of psychological aspects of smartphone use, they're a bit more immediate. So we can kind of start to see some of those trends at an earlier stage. But, you're right to wonder about how our society is changing and what impact that will have on dementia risk. I guess on the counter argument to that, we are much better with managing things like vascular risk factors, and smoking rates, at least in Australia, are coming down. So it's a bit of a mixed bag. We don't know which direction it will go, I guess. There are some things that might increase the risk of dementia, and there are other factors that are probably helping to reduce the risk of dementia going forward.
I might actually just pop in and say as well, even obviously there's potential negatives, but we probably should address there's many positives about smartphones as well, that, it has, the internet and smartphone use has increased the ability to connect to people who might have otherwise been relatively isolated. And loneliness is also sort of, a major factor for people in older age. So there's probably also a lot of advantages that come with smartphones that I'm not being paid by any of the bigger smartphone companies to say that. I just thought actually it's probably relevant.
So for both of you, what's it like working at Macquarie University Health?
So perhaps I should start off just by saying that I haven't actually started work at Macquarie University Health yet. That's next week. So perhaps you could come back and ask me then. But, certainly what I'm hoping to do when I move to Macquarie and start our work there is to help build up the dementia service, both for patients with young onset dementia, that is, patients who have symptoms at an age of less than 65 years of age, but also patients who develop symptoms of dementia after that. So one of the things that's attractive to me about the Macquarie University Health setup is that, we have clinics, we have infusion centres for these therapies, we have MRI and PET scan imaging, we have, all the clinical tools we need to assess and manage patients properly. And then on top of that, there's scope to dramatically expand our research component as well. So the intention is obviously to build on clinical research, basic science research, clinical trials. So we're looking to really expand into, I think, what is a very, very important unmet need in our community. So both for young onset dementia and late onset dementia, the sort of medical assessment, medical treatment, in addition to all the other supports and things that obviously we know about now and we would be keen to continue to tap into, bringing all of that together and combining it with a strong research focus, I think is really a very exciting prospect for me going forward working at Macquarie.
And what about you, Heather?
Well, so I have actually a combined sort of or dual position where I do work at Macquarie University Health, but I also work as an academic at Macquarie University. So I think the thing that I really love about working across both those positions is that I get to be involved in teaching. We clinically supervise students on placement in the MQ Health Neuropsychology service. So we've got this lovely, group of students coming through every year. We work with a really just brilliant team of supervisors. And then I get to sort of integrate all of that clinical work with the teaching that I do in terms of lectures and then in terms of the research we conduct. So it's just a very motivated and driven environment. I love it.
Thank you to my special guests, Professor Burrell and Dr. Francis. This podcast is sponsored by Macquarie University Hospital, part of Macquarie University Health, a trailblazer in healthcare education and research. You can find more podcasts on our website at mja.com.au or wherever you find your podcasts. Thank you so much for listening.